being cared for by other people? Do they have a support group? And I need to know these things. There's so much in the room that we miss. And when we just talk to our patients, I want you to understand that a lot of what we miss is that nonverbal communication. Because what do nurses do when they walk into the room? What is the first thing you see them do? They go to the computer, and so they sit there at their computer and they're missing most of the conversation, because 99% of our conversation is nonverbal in nature. We're missing grimaces, or we're missing the point where they're not using their mouth symmetrically. And so going into your patient's room and actually observing them, using your senses, using your ears, using your nose, because sometimes those smells will tell you a lot of things. Use your senses. You'll be surprised what you can pick up. Now I usually come in and I just talk to them. Hello, my name is Pam Branch. I'm your nursing student today. I'm providing for privacy and I'm washing my hand. Can you tell me your name and date of birth?
Ivan Johnson, February 11th, 1997.
That's a good thing, Ivan. How did you sleep last night?
Pretty good last night.
You did? Well, what do you mean by pretty good?
I got more than 4 hours.
You got more than 4 hours for a nursing student? That's great. Now you notice I move from one side to the other. What am I trying to do when I do that?
Eye contact.
I'm watching his eye contact. I'm seeing if he can move his head, and whether or not he's interacting with me. It makes a difference. And so I move around the room. I don't just stay in one place. Plus, it allows me to see what's going on in the room. Is it clean? Is it dirty? Does he have urine on the floor? A lot of different things. Now, Ivan, I'm going to do a physical assessment on you today. Now, as a nursing student, this may take me 45 minutes. And so what I need to know is you need to go to the bathroom before we start, because I know most students could only hold their bladder like 35 minutes.
I'm all good.
Yeah, are you sure now?
I took care of that beforehand.
Oh, that's okay. I don't want to know anymore. The reason why I'm going to ask him this is it does take you a long time. And you're having to look at your paper all the time. Oh, wait, I need to do this. Oh, wait, I need to do this. And so it takes an exorbitant amount of time for a newbie to do a physical assessment. As you get better at it, you probably get it done completely in about 20 minutes if you do a whole physical assessment. Also, if he gets up, what can I look at? His gait. I can see whether or not he's steady, whether he's unsteady. And this gives me a lot of information about his mobility and his ability to be mobile later on. Now I'm going to start. I'm going to have to touch you. I'm going to listen to you. I'm going to start at the head, and I'm going to move all the way down to the feet. Like I said, this may take me 45 minutes. Probably not as long a period of time for me today. So the first thing I'm going to do is I'm going to look at his hair. And when I look at his hair, I'm going to say, can you move your head forward for me, please? And what am I doing there? Range of motion. Okay, can you turn your head towards me? Once again, I'm doing a range of motion. I'm looking behind his ears and look at his hair. Can you turn your head that way, please? Once again, I'm looking around. What am I looking for? You can put your head straight. Please do not tell your patient right off the bat, I'm looking for bugs. The reason why is because it just makes your patient assume that you think they're dirty and that they're worthy of having lice. I am looking for that, but I'm not going to tell him, and I wouldn't put my hands through his head. I probably wear gloves nowadays because a lot of people do have them. But I actually had a patient that had so much lice in her hair one time it ate a hole through the back of her head, and when you squeezed her temples and pushed it back, pus would come out. And so, yeah, lice are a problem, but there also can be tumors, there can be sores, there can be bumps, bruises, which could tell you maybe this patient has had falls or maybe they're abused. I can look behind their ears, and so I'm looking to see if they have any redness behind their ears. So there's more than one thing I'm looking at here, okay? But never say to your patient, I'm looking for bugs. That's considered rude. Just say, I'm looking to see if you have any changes in your scalp. I'm looking to see if his hair is evenly distributed, and it is. Does he have any patches? Some patients, believe it or not, will pull their hair out. It's called trichotillomania. And they get anxious and they rip their hair out. And so I'm looking to see if he has any patches, any bald areas, and things like that. While I'm at the head, I'm going to go ahead and do my first part of my neurological assessment, which are his pupils. When I look at pupils, I'm looking at two things. The first time I take a pass, I'm looking at the pupil of interest. So I'm going to look here at his left. I'm going to put my hand here. I'm going to shine my light into his left eye. The second time I shine my light into his eye, I'm actually looking at this one. This is consensual. If this pupil constricts, then this one should automatically constrict. Neurologically, that means everything is intact. So when I make a point at this eye, I'm looking at this eye first. The second time I shine the light in this eye, I'm actually looking at this eye. This tells me whether or not his pupils are reacting consensually. Then I'll do it to the other side. And then I'll look at this one. Now he's got real brown eyes, and so sometimes they can be more difficult to see. You want to make sure you have enough light to be able to see it, but not too much light. Let's say your patient's eyes don't constrict. Then you may want to check the light to make sure that's not a problem. All right, you may have too much light in the room to begin with. Also, you want to make sure that it's kind of ambient. These are horrible lights to do it with, these LEDs. And so he does have pearl. His pupils are equal and round and reactive to light. Now I'm going to check for accommodation. And believe it or not, accommodation is checking to see whether your patient is cross-eyed. I want you to look at my pen over here. I want you to look at it here. Now I want you to remember these words. Distance, dilate. Say it. Distance, dilate. So when I look at accommodation, I'm looking at the fact that when the pen is over here, his pupils should dilate. When I bring him closer, they should constrict. All right? So if you can remember distance, dilate, then you'll know as soon as you come down here, they should what? Constrict. Because distance, they dilate. And this is accommodation. I know you see all kinds of other things where they're moving the pens around, and this has actually got to do with cranial nerves, and I know you don't have to learn that, aren't you glad? Then I'm going to look in his mouth. You don't have anything in there before I didn't see it.
No, not at the moment.
She did tell you I was going to look in there, didn't she?
No.
That was very nice of her. Can you bend your head back a little bit? Now, see, I got my last part of my my range of motion of his neck. I'm going to look in his nose. Nothing bad. I didn't really look in there. I didn't want you to feel bad. Open your mouth. Ah. When I'm looking here, it says, "Does he have any sores?" Don't put your hands in their mouth. You don't need to do that. If you find something, then maybe you want to put a glove on and look. But his mucous membranes are moist. His tongue is single furrowed. You can see a lot of times these patients may have multi-furrowed, kind of ugly-looking tongues, and usually that's a sign of dehydration. Also, they can be real filmy or yellow. A lot of times when they're on antibiotics, they may get fungal infections, and so we're looking at that. But his mucous membranes are moist. I don't need to put my finger in his mouth to tell that. He's not a fish. All right? If I was worried about it, then I might. But I can tell that he doesn't have a lot of cavities. His tongue is single furrowed. You already got a pee?
Oh, I have a I'm sorry. I'll be back. I'm
You
sorry.
got a bathroom appointment. You got to schedule him in the PM?
Doctor's appointment.
We don't have to schedule our bathroom breaks. All right, so I just want you to know. All right? Now, while I'm at his head, I'm going to go ahead and check his carotid pulses. I'm going to check one at a time. Why?
It'll cut the blood circulation.
Yeah, cutting off the blood circulation to the brain is considered a real no-no. While I'm at it, I'm going to go ahead, cross your hands for me. Oh, I'm going to cross my hands. Go ahead and squeeze my hands. I'm going to check his grips since I'm already down here. And while I'm at it, I'm going to look at his nail beds. And they should have good capillary flow, less than 30 seconds. And 3 seconds. And so I'm finished with that part. I'm going to do my listening. Never listen through closed. That is just bad. You're going to hear all kinds of things. Now, does anybody have a stethoscope that does not have a bell, which is on the other end? Okay, the difference between the bell stethoscope is that actually for novices, I think it's better to have the one with the bell because you know exactly what it is you're listening to. With people who have just the diaphragm, it's got to do with pressure and how much pressure, whether or not you're listening to the high sounds or the low sounds. And I'm not sure at this point you would understand which one of those you're listening to. I have one of each. I brought this one today because I thought you should see one with a bell. All right? Why don't you take off your first shirt? It might make it easier for me. Strip down for the, we have music. Please don't He's my tie server. I wasn't going to touch him. That's a horrible t-shirt. You didn't really wash that much, did you?
Well, it's stained.
That is a male t-shirt.
There's a
If
reason.
ever there was one.
That's the reason it
A
was on the
woman would
bottom.
have ironed that before they put that on, but a man absolutely not. Okay, now you can either put your stethoscope down or you can move your stethoscope around. Make sure that the patient you're doing this doesn't mind you touching or actually looking at their naked body. Some people may take exception to this, so make sure that when you start, they're not going to have a fit about it. I'm going to listen to his heart sounds. Wish I had a diagram here. I do the what is it called?
All prostitutes.
All prostitutes take money. I was trying to remember what it's called.
Aortic pulmonic.
I know that. It's a mnemonic, that's it.
Yeah.
I use all prostitutes take money. I don't know how to spell
But
prostitute.
don't say that to your patient. Whenever you're doing your assessment, please.
Okay? And what I'm doing is I'm taking the first initial of each of this. If you don't like prostitutes, and some people have this terrible fear of them, then you can use Aunt Polly takes medication. But I just remember all prostitutes make money.
Take.
All, A, aortic. P, prostitutes, pulmonic. T, take, tricuspid. And money, mitral. And that's how you're going to learn it. The A is the only one on the right side. Everything else is on the left side of the sternum. All right? You want to lift up your shirt and show off your chest? Put it back down. No. Okay. I'm going to find, is it clavicle? I'm going to move down. Come on, don't be afraid. I'm not going to touch you. And I'm going to find an intercostal space next to the sternal border. Okay? This is on the right side. It's all, what do I hear? Which one am I listening to? Aortic. Right across from that, everything else will be on the left. So on the second intercostal space, left sternal border, right across, what am I listening to? Now I'm going to go to about the third or fourth intercostal space. Some people are a little longer in the chest, and so it may be the fourth. Shorter people may be in the third. So I'm going to move down. Here I have the tricuspid. Once again, I'm right next to the sternal border. What am I listening to? Tricuspid. And then the last one, the mitral, is midclavicular. So feel your clavicle. When we say midclavicular, we mean right down towards the middle. And here is the what? Okay, you put it down. So when I'm listening to the heart sounds, aortic, second intercostal space, right sternal border. It is the only one on that side. Makes that easy, all right? Then I'm going to listen to the pulmonic, second intercostal space, left sternal border. Everything else is on the left. That makes it easier. Then I'm going to listen to the tricuspid, which is about the third to fourth intercostal space, left sternal border. And then I'm going to listen to the mitral, which is what? Mid-clavicular, about the fifth intercostal space. This is also where you'll listen to your apical pulse when you're given things like digoxin and other medications that might affect the heart rate. Now, I know, do you still teach them Erb's point? You'll have to learn that from them because I don't believe in Erb's point.
I don't even know what Erb's point is, so.
It's supposed to be the maximal impulse. I think some of the paramedics learn it. You're not really it's not really in your best interest to learn Erb's point. Because what you're listening for is that you're listening for the valves to close, whether they are the AV valve or the semilunar valves. And you're trying to determine whether or not there's any leakage. And so what you're really listening for is, rather than a lub dub, you're listening to a lub dub, or that thrill sound afterwards, which would mean that there's some kind of regurgitation from the valves. Some of it is leaking back. And these patients may be more prone to have clots. And so what we want to make sure is that patients who have these murmurs are actually got good blood pressures, that they're not affected by these backward flows. And so what we're really listening for is that extra heart sound. Lub dub, and it'll sound just like that. And that's the backflow of blood against the gradient, against the valves closing. That means that they don't meet quite together and some of it leaks back up. Let's say that there's something wrong with your faucet and you can't tighten it all